Welcome to rePROs Fight Back, a podcast on all things repro. I'm your host, Jenny Wetter, and each episode I will be taking you to the front lines of the escalating fight over our sexual and reproductive health and rights at home and abroad. Each episode I will be speaking with leaders who are fighting to protect our reproductive health and rights, to ensure that no one's reproductive health depends on where they live. It's time for rePROs to fight back. Welcome to rePROs Fight Back. This week's episode, we're going to tackle another human rights violation facing women and girls around the world. More than 200 million women and girls alive today have undergone FGM in 30 countries. Helping me dig into this topic, I'm excited to have with me today Dr. Jacinta Muteshi from the Evidence to End FGMC Research to Help Women and Girls Thrive project at the Population Council. Welcome, Jacinta, and thanks for being here.
Thank you very much. It's a real pleasure to be here today.
So let's start at the beginning and tell us a little bit about where and when and why FGM is practiced.
That's a very big question.
Yeah, and I guess I already slipped and started right away with acronyms. We shouldn't do that. We can use it after this, but FGM, what do we mean when we say that?
Okay. FGM or FGMC means female genital mutilation cutting. It's a cultural practice found across possibly now we think 30 countries in Africa, in Asia, and possibly even South America. And FGMC is procedures that involve the removal either of partial or total external genitalia of females, and for non-medical reasons.
And there's a wide range of what happens, right? So,
Yes, that's true. WHO, which is the World Health Organization, has identified 4 different types of cutting. They range from very extreme forms to forms that are sort of pricking, nicking, or cutting at the least extreme form. So the forms, therefore, will also vary depending on the cultural group. Groups also, or communities that practice for a variety of reasons. They practice because it's how they prepare their girls for marriage. They practice because this is how they prepare young girls for womanhood or adulthood. They practice as a means of ensuring chastity or purity. Or they may also practice, depending on the community, because they consider it to be beautifying of a woman's genitalia. And they're practicing it, I know I said chastity, but sometimes it also goes beyond that in the sense of managing women's sexuality. So those are the reasons it is practiced, but the reasons will vary from community to community. The other thing to note about it is that our current estimates show that something like 200 million girls in 29 countries have undergone FGMC. And we also think that 30 million girls will be at risk, 30 million girls under the age of 15, given our current estimates and research, are at risk of also facing FGMC.
Well, I think that's important. We're talking about under 15 is that it usually happens on very young girls, right?
Yes, generally in most communities, and given the evidence we now have, it tends to be between the ages of 0 meaning from a few days after birth, to about 15 years of age. That's the most common age group at which it happens. It very rarely happens on adult women, except in some communities. And also, we are seeing that when a woman hasn't, or a girl hasn't been cut, that it can happen again, or not happen again, it can happen later when she's getting married, or when she is married, or when she's giving birth to her first child.
Okay.
And this is communities for whom it is a cultural practice.
Okay. What are some of the biggest pieces of misinformation that are around FGMC?
One of the biggest ones, actually, is that there's the tendency to think that people practice because it's a religious obligation. We now know, and in fact from engaging with communities that have always practiced it because it's religious, that it is not a religious decree, that there is no basis in any religion to cut or to practice FGMC. The other often misinformation around this issue is that, and it goes in two ways, that either it's a woman's issue, in other words, it's women who practice and cut and are responsible. And we know that that is actually a rather simplistic explanation of it. Because women, yes, indeed, do prepare their daughters for FGMC, but they're doing it because they live in communities where it is the norm. In other words, you need to fit into your community. So it's not that women make this decision because, and therefore the responsibility is entirely theirs. In some communities, yes, men are also involved in sustaining the practice. But we also know, increasingly given our data, that there are an increasing number of men who are not supportive of the practice. So I think those two things have to be understood more in the sense of the complexities around them. That is not a simple answer.
So, we touched on this a little bit, that a lot of people view FGMC as being rooted in social and cultural norms, and so that there's no way to change that, right? So what would you say to those people?
I think one of the biggest findings we now have is actually understanding that FGMC is a social norm. And that means that it is a shared behavior that people who practice it do because they believe that others in their community are also practicing or cutting their daughters. And so one of the lessons we've learned over time is that one of the ways to begin to address social norms, because they're so deeply rooted in communities or underpin many cultural practices, is to actually begin to engage with those who influence, what we call cultural influences. So the kind of conversation can begin around the importance of these cultural practices. It's also meant the need to understand how do you change a social norm,
right?
Given the power of social norms. And some of the current work we see where there's been some successes has been mainly because you're engaging communities in dialogue and conversations around norms, so that you're understanding why it's important to them. You're understanding, therefore, what alternatives can be offered if the intent is the reasons I highlighted earlier, right? How do you manage the chastity of young girls? How do you protect your young girls? So in conversations, you can begin to think about and understand some of the concerns that families have around their daughters. And how can those be addressed beyond cutting their daughters?
Addressing a social norm or changing cultural norms seems really complicated, and that it would take a really long time. So how long do you think, tackling that would take?
That's actually a very difficult question.
Right.
In many ways, because the work around social norms or using social norms change is relatively recent work, or at least the focus on it is relatively recent work. There are examples of projects, for example, the Tostan project, that has used this for longer periods of time. And we're looking forward to actually learning how that works. Part of the constraint and challenge we faced in this work has been understanding what is it that people do. When I say people do, I mean those organizations, those advocates, when they seek to support abandonment. The challenge for many is that they're not often documenting in ways that help us understand the steps they've taken, the way they organize how the particular interventions will work, what informs the selection of particular interventions that they have, and are they monitoring and evaluating the interventions that they have. We're sort of saying the same thing in terms of what I'm raising here. Because when we speak of social norms, it's important to understand the power of the norm, the fact that women and men are in relationship to each other. Societies have to think of and do figure out ways in which they manage those relationships. And we know, yes, in many cultures and in many societies, women's positions tend to be sort of secondary or lower than those of males. So those conversations are therefore going to be actually speaking to or targeting what are very complicated issues and very challenging issues in communities. So in some communities, we've heard it moves quite quickly, that when these types of conversations begin to happen, people may begin to consider alternative ways of addressing the issue. A good example would be what we see in Kenya, and is called the alternative rites of passage. So here there was the understanding that for this particular community that circumcised or cut their girls in preparation for womanhood we're doing it for those very reasons. So their girls would go through particular ceremonies, particular rites of understanding what does it mean to be a woman, what does it mean to be a mother, what does it mean to become an adult, how do you fit into the society in which you were born. So the question then became, can those things still be done without cutting your daughters? So an alternative rite of passage was developed in consultation and in communication with those communities.
Mm-hmm.
And what we've seen now over time, because this has been in practice over time, is that those communities moved to alternative rites of passage. It's one of the interventions that we've seen as being successful. So, and when we have evaluated them, we've seen there is change in attitudes. So I think the work going forward will be to actually seek to understand, did behavior remain sustainable? We think it has, because when you look at the same community that I'm speaking about that have alternative rites of passage, we see that prevalence rates have dropped or have been on the decline over time. So what that points to us or raises as a key way of looking at this work is the need to understand always when you speak of FGM, when you seek to address issues around FGM, that you understand the specific cultural practices of communities, that there is no one blanket response. Mm-hmm. It's about understanding why communities are cutting their daughters and what would encourage them to abandon the practice, and therefore what types of responses you would need to put in place, and those responses would be diverse and would be varied because FGMC is very ethnically based in the way it's determined, in the way in which communities respond as well.
I think that's really important because so many times advocates are looking for, the so-called silver bullet, the one thing we can tell people to do that's going to fix X problem, and it's really important to see that it's really complex and you need to look at a whole range of things.
Yes, you certainly do. And if you look at the work as it has evolved over time, you'll find there have been so many different types of approaches put in place, right? There are approaches in some communities that focus on health approaches. And communities where you have the alternative rites of passage I've just mentioned. There are communities where social change, particularly social change through community dialogue, have become the mode in which you engage communities. We also now have countries where the implementation of policies and law has been one of the ways in which those interventions roll out. And because we are studying what is happening with all of these interventions, we also need to highlight that there have been inconsistencies in the way those interventions are implemented. So they're not always implemented in the same way. Mm-hmm. So there's need to really understand what were people doing, because they'll often call them the same thing. So you may have people saying we've had in our community even alternative rites of passage, and you look closely, but it's actually not necessarily implemented in the same way.
Right.
People say they have community dialogue conversations, you look closely, but they're not actually the same. Countries will implement laws, and you look at the content of the law, they're not the same across countries. So the results are going to be different. So I think the biggest contribution we will be making as Population Council is to begin to understand what exactly has been happening around interventions. How have nation states responded, particularly those with high prevalence, and where we've seen trends change, what have they been doing right? Where we've seen communities stop the practice, what does that look like and how did that happen? So that is the work of research, and that's the evidence that over the next few years we hope to be generating and sharing more widely.
Oh, good. So this leads perfectly into, do you want to tell me a little bit more about the work that you are focused on?
So beginning in 2015, we were in receipt of a grant from DFID, that is UK aid, to undertake research around FGMC to address the gaps that persist around our understanding of FGMC. And it's important to note, actually, that many years had passed before there was interest again in looking at the gaps and providing resources to support research. That hadn't been there since sort of the previous commitments, actually from USAID, which laid the foundational work of looking at FGMC, for Population Council, that is. And so this recent commitment of resources to address those gaps has been a very positive step forward. And so we have primarily 4 broad areas of research we're looking at. But within these 4 broad areas, there is a multitude of research projects. The first broad thematic area of our work is called Building the Picture. And building the picture is to keep deepening and broadening our understanding around the practice of FGMC. Because there are countries where we have very little data or information or knowledge about the practices of where and when and why, and if there's any change happening. We don't have enough information. So as I said earlier, we currently have, for example, national prevalence data for 30 nations or 30 states or 30 countries. But there are countries where we know that there is FGMC and there is no national data available, such as India, Sri Lanka, Iran, Malaysia, and Pakistan, to name some. And also, we don't have prevalence data for the United States either. Mm-hmm. So this is part of building that picture. Granted, our research work, is focusing on 7 African countries. Those 7 are representative of countries where there's still high prevalence and universal prevalence. And then countries where we're seeing, yes, there was high prevalence, but it's beginning to change in positive ways. And countries where there has been significant changes in the practice. So that's building that picture. And we're even bringing new tools with regards to how you make sense of survey data, which is the main means of collecting much of the prevalence data that we have. And what that is doing, for example, is we are saying it's all very well and good to have national prevalence data because it's how we even begin discussions about where FGMC is. But for purposes of policy, for purposes of strategic investment, for purposes of targeting interventions, you need to be able to identify what we are calling currently the hotspots, which means you have to move to subnational data. So we have begun, our first example is Kenya. That's where we have begun the work. And this year we are expanding it to Nigeria and Senegal and hope to expand it to the other countries if resources allow. So that's the main big theme about understanding what the picture looks like. And it may be interesting to add here that one of our early findings also around building the picture is increasing medicalization with regards to FGMC. Yeah. So the percentages don't seem so high, they're 27, 28%, but those percentages represent several million young girls. And so that is something that's pointing us in the direction, that's what the evidence is doing, pointing us in the direction of where we need to be working.
And do you just want to maybe stop for a second and talk about what medicalization is? I know what you're talking about, but I feel like a lot of our listeners might not know.
No, that's actually a very good question. What that means is that as we look at communities now, our studies are now, we are noting that communities are moving away from, increasingly moving away, not all, but many communities are moving towards using healthcare providers. In other words, health professionals, like doctors, like midwives, like nurses, to provide the service. And even that in itself is interesting because in Egypt it will tend to be medical doctors. Right. While if you look at Sudan and Somalia, you will find it's mostly midwives and nurses. And in some contexts you will find, for example, Nigeria and Kenya, that it will be some doctors as well and nurses, but primarily medical doctors has been Egypt. That's what the evidence currently shows. So that's what medicalization means.
Right.
And
good, perfect. Yeah. No, thank you.
And so that's the first theme. And we'll probably come back to medicalization because there's some interesting things to talk about there.
Okay, good.
And then the second broad thematic area, again with several research projects underneath, is the one where we're asking the question, what is the nature of interventions? Are they working? Why are they working? Where are they working? Well, what have people been doing to respond to FGMC? of particular interest, of course, because people want to learn what will work. This is early work yet, but the evidence should be coming in very shortly. And I've shared some of the types of interventions, such as health approaches, such as alternative rites of passage, such as community dialogue. Those are some of the interventions that exist. What is important to, again, maybe reiterate here, which I said a little earlier, is the absence, when you look at interventions, the absence of adequate documentation to help us understand why people or why those who intervene have intervened in the way that they have. That's sort of the limitation. But we're still going to try to make sense of it because our research is retrospective. We're looking at interventions that have already been undertaken.
Okay.
So we can learn from them moving forward. And one of the things that is also emerging and is an important piece of evidence is that as we move forward, we may need to be investing more in supporting the ability of those who program and intervene to be able to monitor and evaluate. It's often the missing piece in this work.
Okay.
And I can understand why, because what people want to do is respond immediately to an issue that they're facing, an issue that has challenged us for a long time. But those other pieces with regards to, but why are you doing what you're doing? Why are you implementing this particular type of intervention remains very, very important. Another point to raise here, just with regards to an intervention, I'd mentioned earlier that law is a form of intervention. The work of advocates over the last several years have seen many governments now create policies and create laws. But what the evidence is telling us is that what laws have done to date is to depress reporting, essentially meaning people may not tell you if they've been cut.
Right.
Because essentially the law has criminalized the practice. So it'll go underground. And so that means how will we then really understand what is happening? But this is not a comment against law. You do need laws. You need laws because they create the environment for us to do the work we need to do. Because it shows that the state is supportive of the intervention. So it's a very important piece of policy. What is missing is the aligning of the necessary resources or the necessary understanding of what you need to support the implementation of law. So we have a study we've just developed a protocol now, so it's about to be implemented, that will try to answer that question. The question being, when and why do people obey law? And those insights, and we're looking at communities where, of course, FGMC is prevalent, might begin to give us some insights into a possible way forward. What is it that we have not done? What is it that's missing when we create laws and policies, important as they are? So that is an important current evidence out of looking at law as an intervention. And then the third, and I'm just highlighting one example of an intervention. I mean, the interventions are so many. We also looked at a third theme, which is what are the wider impacts of FGMC. These particular research projects will begin and have just completed that work, looking at what are the possible associations between FGMC and early child marriage, which is of great interest to many people. What are associations with HIV/AIDS? Currently, we don't see strong correlations. What are the associations with fistula? So the beginning baseline work is ready, and it's actually available to the public. It's up on our website and can be looked at. But what's key about those studies is that in the history of this work, there's been mostly sort of an anecdotal evidence that there is associations.
Right.
So what we've done is actually produced the evidence that currently this is what the evidence shows, but this evidence says to us that we may need to dig deeper to understand actually whether there are associations that were not evident when we first started looking at the issues. So, for example, when you look at FGMC and early child marriage, we know that there may be communities where when there are changes contextually, let's say conflict, displacement of families, families may begin to cut their daughters earlier because the societies have been destabilized and they're marrying off their girls earlier because the context is changed. They can no longer look after their daughters. So sometimes there can be that sort of association we see happening earlier. But there's also communities who practice early child marriage who do not cut their daughters. There are communities that cut their daughters and do not practice early marriage. There are communities, we've also just noticed, who will begin to move away from either early child marriage or FGMC, but not both.
Okay.
Yes. What we want to understand is why. Like, why would they
Why one, not the
one
other?
and not the other?
Mm-hmm.
In fact, that's the sort of the final question in the report that's just come out. So that means there is more work to be done. And that's the nature of research. You start to answer some questions, and as you do that, new questions emerge.
Right.
And the decision has to be made, do we now follow that question, right? So that's where that is. And then there is the last research theme where there are gaps, which was what would be, it's broadly called, the theme is broadly called measurement. And here we're asking ourselves, what are valid measures of change? How do you measure change? How do you know that change has occurred? And the complexity here is that we're trying to determine how you know that there's been a social change, because we're talking that this is a social norm. How do we understand that that change has occurred? So those are the four very broad thematic areas of our work.
Good. So a lot of it is focused on data and evidence, and that's really important. But can you talk a little bit about why data and evidence is so important to creating, abandoning these social norms?
What is clear is that reliable data is essential if you are to understand whether you've made any progress to begin with, right? So this is actually why data is so important.
Right.
Data also tells you where you need to work. So that already is an argument for why you need to have data, so you can understand what is working. And data is, yes, people might say it's just mostly numbers, but data is also, we do both quantitative and qualitative work. So it's both, we're asking people to talk about their experiences, and we're also counting what is happening. So it's, to put it simply, right, it's more complex than that. So it is absolutely important to have it, because it is showing us, and I think a good example is evidence is showing us where shifts are beginning to happen. And really good examples of that out of our evidence is the first one I mentioned earlier, which is medicalization. Because we were looking at data, we were looking at prevalence data, we're looking at trends, we were able to see that there is a move towards medicalizing. So that's a very important finding.
Right.
Data also tells us who is medicalizing. So that's really important. Data tells us, to use the same example of medicalization, when you look at Egypt, that mothers or families have handed that responsibility of decision-making to doctors.
Oh.
So they'll go to a doctor and say, is it time to cut my daughter? Can I cut my daughter? Will you provide for the service?
Mm-hmm.
So it seems this responsibility has gone on to medical doctors. So medical doctors are those who advise families when and whether to cut. And that in itself tells us that interventions are going to be directed at doctors as well.
Right, yeah.
They're going to become a key target for any interventions that we think about. And so our work has already begun to craft what those interventions might look like, given the lessons that we're learning around medicalization. So that's important. Data, and if we pick a different country like Sudan and look at what the same medicalization data tells us. I said earlier, it tells us that it's mostly midwives and nurses. Now, when we start talking to people in the field now to get sort of the qualitative aspects of it, healthcare providers, and when we have this now on record, would say, if I don't provide the service, I will be ostracized. The sanctions are very high for not providing the service. The sanction is coming from the community. So for healthcare providers who have an ethic of do no harm, you can see the complexity and challenge they face, because those sanctions are very effective. A sanction can be, as was shared, that you will no longer be invited to or be welcomed into community activities. And we know that in the communities in which we work, people are very interconnected, because we're talking about village communities. In this particular instance, it was a rural community. So how does one conduct their life in the absence of having these relationships with the broader communities in which they live? So it's very effective. So if a healthcare provider chooses not to, they'll just look for one that will. So it means that there's also money in it, right? They're making money from providing the services, not for free. The other important piece of evidence coming out of the medicalization study, again highlighting the power and importance of evidence, is that in Egypt, we're seeing that FGMC is being called refinement, right?
Oh, I hadn't heard that.
And it's cosmetic. So what does this therefore mean with regards to how we begin to talk about FGMC in those communities? This is the value and the importance of evidence, right? It's bringing this forward, this new information about understanding how that is the change that's happening in Egypt. So change with regards to who is providing cutting and when. When, meaning we see that the age of cutting is also shifting or changing. In many communities, girls are being cut at a younger and younger age. There are communities such as Nigeria where girls have always been cut almost within 10 days of birth. So that is not a consequence of medicalization or a consequence of change. That's just what they've always done. But generally speaking, the age of cutting is dropping. And part of it has to do, and this is the contradiction, has to do with the fact that we have laws. So this is how this is one way you can make the issue sort of become invisible or disappear.
Right.
Because girls wouldn't remember they have been cut. If they've been cut at such a young age, they won't even know they've been cut because for them that's just how their genitalia looks, right? So that's what will happen there with the decreasing age of cutting. So decreasing age of cutting because we have laws now that are making it more and more difficult. And also because some parents have said, or mothers also say, if you cut at a younger age, it's less painful. That's also one of the other things that we see begin to happen. That's not to say that I'm saying that's what is true,
right?
But that's what is often sometimes presented. All of those reasons as to why the age of cutting is changing. The other shift that we're seeing is in type, meaning the type of cutting. So, as I said earlier, we know there are 4 types of cutting or circumcision. And in communities, and good examples are probably among the Somali community, who have type 3, which is the most severe form. So one of the things we are seeing in our research is that the communities say we are cutting, sort of moving towards less severe forms of FGMC. The problem is we actually don't know whether that's true or what that looks like.
Okay. Because
you'd have to do clinical examinations,
right.
Actually, and it's not ethically possible, of course, to do that. But they're also saying that they're moving towards lesser forms because that means it'll create less harm. And this is the contradiction of the work, because we have often, and we still do, say FGMC is a harmful practice. So that discourse has been a very powerful one and possibly very effective in the sense that, therefore, families who cut their daughters, not because they don't love them, they cut them, they would, as they
right.
argue, because they love their daughters and this is a cultural practice. So they look for means of practicing and creating less harm. So sort of harm reduction strategies. Thus the medicalization. Thus less severe forms of cutting. Thus cutting at a younger age. Now, this is not consistent across all communities. I'm sharing that as examples of some of the evidence we're seeing in some of the communities where we're exploring this. So there's also the use of the word sooner to imply that it's also lesser forms of cutting. But when we ask what is sooner, we find that the responses are extremely varied and diverse. So that means we really do not know actually what sooner is, even though that term is being used. And also, it's problematic to use the term sooner, as some religious leaders have told us, because what that does, it seems supportive of the practice. It's as if to say, yes, it has actually got support in religious text. And the other complication linked to that is there are religious leaders who continue to support the practice. And there are also religious leaders who are not in support of the practice, and they've become advocates to end the practice. So those are also, again, just highlighting the complexities of this area of work, but complexities that do have to be understood. The other change that has happened, and again, it is a result of interventions because people are more aware, there's been a lot of creating knowledge and understanding, is that we see a lot of cross-border also movement or practices. And what this means is that people will move from one country where the laws are strict, and even if they're strict or not strict, it's more that there is sort of more follow-up and enforcement.
Oh, gotcha.
So people will cross to a place where that is not the case, right? Where there's less enforcement, or where there may not be a law to also cut their daughters. So that says to us we will need to be looking at these sort of cross-border issues to understand them better. What would the nature of the intervention be? And the other change that is coming out of the change that we see manifest when we look at our data is that there are men, increasing number of men, and this I think we didn't know, that are in support of ending the practice, or at least in support of helping interventions to end the practice, as they understand that they don't want this to be a practice that they continue with their daughters, or they recognize some of the harms, because they can be, with regards to their own partners.
So we've talked a little bit about what are the impacts of FGMC on women and girls. Can you maybe dive a little deeper and talk about some of the impacts that women and girls are seeing?
We recently completed a study that looked at the impacts on girls and women, and primarily the health impacts. And what was important about that is we saw that we generally tend to know the physical impacts, right? We know the pain, the trauma, consequences, the bleeding, to name another example, that is a consequence of FGMC. What we haven't paid attention to in terms of impacts is the psychosexual impacts of FGMC. So our evidence, or our recent research, is beginning to highlight the need to be focusing in that area, in that direction. We know that there are instruments for example, to measure the psychosexual aspects of women's and men's lives. But we also found, because of the research we've just done, that those instruments are often not culturally sensitive. And so our evidence is suggesting that there may be need as we move forward to begin to develop the kinds of tools that would be much more helpful, particularly to healthcare providers, so that healthcare providers would also be recognizing what they're faced with. The immediate response will be, how do you manage bleeding? How do you manage pain? And less about what are the psychosocial impacts of what has just happened and how do you manage that. That takes skill, that will take expertise, that will also take resources. And so the value of the evidence is that it's pointing in that direction and saying that this is where what we need to see happen. So those are the impacts that we see.
Okay, good. And so you talked a little bit about that. We're seeing a decline. Can you talk a little bit about what regions we're seeing these declines in?
So, for example, the prevalence data currently shows us that overall prevalence rates could be said to remain high, generally. Like I said earlier, we have something like possibly 30 million girls at risk, right? But when we look now more specifically at countries, we note that steady declines are evident in Kenya, in Nigeria, in Togo, and Benin, our current findings. When we look at the countries where FGMC is universally practiced, such as Somalia, Guinea, Djibouti, Egypt, and Sierra Leone, we note that in 3 of them, Somalia, Djibouti, and Guinea, there's been hardly any change. But in the other 2, which are universally practiced, meaning the whole country, it's very high prevalence, Egypt and Sierra Leone, we're seeing there's been change over time, right? So that's positive. And then there's countries such as Ethiopia and Burkina Faso, where the prevalence is high, but we also are noting that there is some actually very positive trends. And this goes back to the point I made earlier about national prevalence rates, that they make or render invisible understanding actually what's really happening on the ground. So that when you go closer to look at subnational data, you can begin to see that even within one country, there'll be communities where it remains universal at 80 or 90%. In the same country, there'll be communities who practice where there is a steady decline. In the same country, there'll be those who've stopped the practice. So that's why the national data is often not very useful in terms of where should we work. The other interesting thing about that is because the subnational data pulls us into countries to look more closely at communities and to understand where interventions have been in the past and whether they've worked or not worked, is that it also helps us see some of these contradictions. So there are communities, for example, the Kisii in Kenya, which tend to be relatively very well educated, yet they cut their daughters. And then there's communities such as the Kikuyu who we've seen a steady decline, and they too are communities where there is the high education of daughters. We've seen it essentially move towards ending the practice, and among some of them, the practice has ended. So the study that we're just concluding now is actually looking at those communities to make sense of what was it that they've been doing over these past, essentially 2 decades, that has brought about this change. Then I'll have hopefully the answer for you by the end of this year.
Oh, great.
Where do we want to go from here, given that question around data? And it's true that over these past 2 decades, because that's the period we're focusing on, given our earlier work as the council, Population Council, that we recognize, yes, there's been progress, especially progress in our understanding and the interventions that we see, not ourselves, but that others have implemented, and that we're now studying to understand better and increase our own knowledge. The picture still remains incomplete, right? So that's why we're here. But we have something to offer in the sense of saying that to accelerate this progress, we're going to need to invest more in national data, because we do need to begin there. Mm-hmm. And then especially for missing countries, your own included.
Right.
And then move from there to improve subnational data collection so that we are more informed about how we target, and where it's worked, how we amplify, and where we've worked, we can pat ourselves on the back and say, oh, this is what works. This is how we can support communities who are seeking to change. Because even in communities where there is the practice, there'll be individuals who want to change, but for whom it's very difficult. So how do you create the kind of enabling environment that where that becomes possible for those who are contemplating change? Because those will be in those very same communities, as there'll be those who are not considering change,
right.
As there'll be in the same communities those who've actually stopped, but it's very private still, and nobody knows that they're not cutting their daughters, is also what we're learning. The other thing that I want to raise here about where do we go from here is the need to test interventions. That might sound very sort of maybe research-based, but testing interventions means that we're calling for the need for high-quality evaluations of interventions. We're calling for impact evaluations. We're calling to testing what people have actually done so we can learn from it, so that we can scale up. That's really where we need to go, so we can enhance our understanding of what works, and so that we can build even more the evidence that informs what we do going forward. The other point about where do we go from here is to be directing resources towards investing in monitoring and evaluation, which means as the interventions themselves are happening, that we are building capacities or strengthening the capacities to describe interventions, to understand the interplay between components of interventions as they move forward. Again, that will inform how we move forward, because that's really where the work is. And then lastly, with regards to where do we focus efforts, without question, where prevalence remains high, but also where change is underway, even though prevalence remains high, because it means that's an entry point, because we can see change. We should also focus efforts on where there's a steady and long-term decline, because here we will have lessons that can inform what we're doing. but with caution when I say that as I said at the start, the practice of FGMC has different reasons, rationales, why it is practiced and how it is practiced. So the lessons there must be lessons that we look at critically and reflect upon as we think about, would this work here and why would it work? And then lastly, again, just to repeat, because it's become really important from every quarter, which is that the subnational hotspots are the ones that will require specific efforts, because without question, that's where the work needs to be done, without question.
Great. Well, thank you so much for being with me today, Jacinta. It's been a pleasure talking to you. Thank you.
Well, thank you very much. It's equally been a pleasure for me to be here talking with you.
For more information, including show notes from this episode and previous episodes, please visit our website at rePROsFightBack.com. You can also find us on Facebook and Twitter at rePROsFightBack. If you like our show, please help others find it by sharing it with your friends and subscribing, rating, and reviewing us on iTunes. Thanks for listening.